So welcome everyone. I'm Adelina Comas Herrera, the director of the Global Observatory of Long-Term Care, and I'll be introducing today's webinar. I'm going to start by telling you a little bit about the Global Observatory of Long-Term Care. You may have seen it before, but we always have new webinars to tell you about. So the Global Observatory of Long-Term Care is a knowledge exchange platform. And our aim is to support learning across countries on how to improve and strengthen care systems. It's part of the international long-term care policy networks, and it's very much driven by people's willingness to share their work, collaborate, and have fruitful discussions. It's powered, as I said, by the willingness to share knowledge. We have a series of GOLTC publications, which include some country profiles, a growing number of blogs, and we're also building a library of methods and topic guides. And the real heart of the observatory are the interest groups. Each of them organizes their own series of webinars, as well as sharing relevant publications and resources, and each interest group has its own page. And I'm very excited that today we have a webinar of a new interest group on unmet needs, inequalities, and care poverty that we also summarize as UNICAP. Just to tell you a bit more about what's coming in the next few weeks, we do have a really busy time of the year. Let me go back. It's really exciting to have so many webinars. This Thursday, we have one on reflecting on home-based care provision from the South. We're going to hear about experiences from Brazil and South Africa. On the 5th of November is the first webinar of a new interest group on qualitative methods, and they're going to be discussing qualitative process tracing. 7th of November, we're going to hear again about African context. We're going to hear about all the people with disabilities and social protection. I think we have presenters there from Kenya and South Africa. On the 11th of November, we'll hear about evidence-based pain management. We've got then one in Spanish from the interest group on long-term care in Spain on care in the community. 14th of November, got quality management in long-term care, some insights from France, and then a new webinar as well for a new interest group, which is the innovation in long-term care. And we'll hear about innovations, challenges, and opportunities. On the 28th of November, I'll tell you a bit more about that in a second. It's our celebration day of International Day on Care and Support. And on the 10th of December, we'll hear about using AI for qualitative research. And as I said, very excited to announce that on the 28th of November, we're holding our celebration of the International Day of Care and Support. And the theme this year is on changing the narrative on long-term care, and we'll be addressing what we consider to be negative myths that are not helpful in terms of improving long-term care systems, and wondering and looking at examples of how we can use evidence and practical examples to change the narrative. We're organizing this with partners in Australia and Chile, and it's going to be a very long day. We're thinking we're going to have about 16 hours of a presentation. Some of them will start really early in the European morning because they'll be starting in the afternoon in Australia, and we'll end the day in Chile. If you'd like to take part, please let us know. You can put a comment on the chat, and my colleague Naz, I think, is sharing some links so that you can also sign up. And with that, I'm going to end here. Just to say, if you want to join the observatory, this is the QR code to join. You have to create a profile to become part of the observatory. And if you're already there, of course, welcome back. And with this, I'm going to hand over to Teppo Kröger, who's going to introduce the interest group.
So, welcome everyone to the first webinar of a new Global Observatory Interest Group, which has quite a long name, Unmet Needs, Inequalities, and Care Poverty. And as we heard from Adelina, we also use the short abbreviation of UNICAP. I will tell very briefly why this name and why this short name as well. But first, before telling about the network and its background, I want to very briefly introduce the key kind of idea behind the network. We who have been involved in research on long-term care, disability care systems for a while, we know that very often research focuses on input issues and variables, very often on expenditures. How much money is used on care services or support for informal family carers, for example, or on outputs. So what is done with this money? How many people are getting different kind of services? These are very, very usual variables, particularly in comparative research if we compare care systems. But the problem is that even though these are useful indicators, they don't really give an answer to the question that what are the outcomes of these services, these support measures. Particularly, we don't know whether these policies, these services, these support help people who need help to receive the support they need, whether they receive adequate support. That is the question that remains unanswered. So that is why there are quite many of us among researchers think that actually the evaluation and the comparison of care systems and of care policies, it should change its focus, at least partly. We should also include more attention, put more attention into the outcomes, not only on these inputs and outputs. In particular, we should give more attention to the question whether the needs of people who need care and support, actually whether these needs are met or not. Also, in care research, there has been a very strong focus on carers, family caregivers, and also care workers, which of course is a very necessary focus. But at the same time, the people who need help and support have remained a bit in the shadow. So this approach that I'm here speaking about would put people in need of help and support and assistance, put them in the center of the attention. You could see that in the name of the new group, it starts with the concept of unmet needs. And this concept is already quite established. It has been used particularly since the 1990s. It has even a longer history, but particularly since the 1990s, it has become a quite popular term, particularly in American gerontology. And a bit later, in the decades after the start of the new millennium, there has been more and more research on unmet long-term care needs, also in Europe. I think Spain was actually a pathbreaker in Europe in this research, followed quite soon by the UK. But now we have this kind of research coming from many different European countries, and not only from European countries, also from several Asian countries, also several African countries, probably also Latin American countries, even though I must say that I don't know myself that research. Anyway, this term has become a usual term in research on long-term care. However, recently, I, with several colleagues, have been also suggesting another concept that is also included in the name of this interest group, and that is the concept of care poverty. And why this has been suggested is it tries to connect the gerontological studies on unmet long-term care needs that I already mentioned to social policy literature that has been coming out for several decades on care systems and also on social structures. And as well, there's this idea that maybe research on care could be more closely combined with the research on poverty and social inequality, particularly learning some approaches that are used in that research and applying them in research on care. So the kind of the main idea is that care poverty would be a parallel concept to to poverty, not its sub-concept, but a parallel concept. So when in poverty, it is a question of deprivation of material resources and issues that are linked to this. In care poverty, it is about deprivation of care resources, but including both informal and formal care resources. So both family care, support from social networks, public services, private services, services and support from the voluntary sector. So everything. And here is the definition that we have been using on care poverty, showing that it's a result of both individual and structural issues, and it's about people not receiving sufficient assistance, sufficient support, sufficient care. Now I'm moving to the UNICAP network, and this is maybe a bit special interest group for the Global Observatory because there is a history. So the history actually goes back for 5.5 years to January 2020, when I, together with the chair of today's seminar, Nicola Briblecom, we organized a research workshop at the LSE in London, where we got very nice representation from around 15 different countries. We were around 20 to 25 people meeting there. I think it was 2 days, if I still remember correctly. And during the meeting, we decided that we want to keep working together, collaborating, developing these discussions. So we organized ourselves as a research network, and then we gave this name Unmet Needs, Inequalities and Care Poverty, and the brief name UNICAP. So this name actually goes back to January 2020, and we have been using it since. And you can see that in the title there are these both concepts, unmet needs and care poverty. So we have been very open to anyone to use these terms the way they prefer. So some of the network members have preferred to use the term of unmet needs, others have preferred to use care poverty. Some, for example, myself, use both. So this is maybe explains why both of them are in the title also now of this interest group. We are also interested in having new concepts. I know that, for example, some Norwegian colleagues use the term missed care. There could be also other new terms. That in any case, the question is whether people who need help and support and assistance, whether they really get it or get it enough, or whether it fits their needs. Then we decided quite early that we also want to produce something in written form, either a special issue of a journal or a book. And it became a book. It became a book project, and then Nick and me were joined by Ricardo Rodriguez, one of our speakers today, and also Kirsten Ramery in editing this book. And this book came out in May this year, published by Policy Press. It's open access, so it's freely downloadable from the Policy Press website. And in the end, we had authors of chapters from quite a number of countries: Austria, Denmark, Finland, Germany, Hungary, Portugal, Slovenia, Sweden, the UK, as well as from Australia and Canada in the author group. So it's quite an international group and really tries to push forward the discussion on unmet needs and care poverty through kind of international discussion and collaboration. But now UNICAP has become an interest group of the Global Observatory, and when the book project was pretty much finished, we started to discuss that what do we do next, and particularly what do we do with the network. Is it going to end, or does it have a future? Over the years, we had experienced quite a lot of interest in this topic of unmet needs and care poverty. For example, Nick and me and Lina van Askrodt, a colleague, we have been organizing thematic panels in transforming care conferences, in several of them, and we have always received quite a lot of abstracts for these panels. Also this year, when the conference was in Helsinki, unfortunately we couldn't accept all the abstracts because there were just too many. Well, not too many, but it means that there's really seemed to be an interest for these discussions. So then we thought that maybe there is a future for this network, and maybe it could be even extended and opened and do something new. So then we decided to suggest to change this earlier network into an open network, into an interest group of the Global Observatory. And then Ricardo joined me and Nick in coordinating it. And we are very happy that Adelina and her team accepted us as an interest group. And this means kind of a new start for this network and also its work. And we are very happy that now we are here. We are having the first webinar of this new interest group. And even it's the first event today of this network, but we already have over 100 members from 36 different countries, if I count it right. And this is really quite amazing. We all three of us are very happy that so many people have wanted to join the network. We would very much like to have a long discussion with all of you today that how should we take the network forward, what kind of activities we could have and should have. Unfortunately, we are too many for having a long discussion on that, and our time is limited, but we really hope that if you have any ideas or suggestions what we should do together as this new interest group, please put them in the chat so that we can get all these ideas and then come back to that later in our next events. And at this point, I will give the word back or give it to Nick, who really has been with UNICAP from the very beginning.
Thank you, Teppo. I was a long time. It feels like a long time ago now. A lot's happened. I'm Nick Brimblecombe. I work. I'm a researcher at the Care Policy and Evaluation Centre at London School of Economics and Political Science. And I'm just going to introduce the speakers and share it. Keep everyone to time. So we're going to have two speakers. We'll have Jibby and then Tasha speaking for around 10 minutes each. Then there'll be a very short amount of time for some questions of clarification, and then we'll move into a discussion which is led by Ricardo. If you've got any questions, please put them in the chat, and if we don't have time to answer everything, hopefully the speakers might be able to get back to you on things, or we can. And also please do put any suggestions of what you'd like to see of future activities from us as a network in the chat as well. So I'll start by introducing Jibby Matthew Puthen Parabil. Jibby, I'll let you mainly introduce yourself. So floor's yours.
Yeah, thank you, Nick. I will share my slides. And... oops.
I should add that Tasha and Jibby are two of the authors of the book, as is Ricardo. So We haven't got all the authors here, but it's nice to have some of them represented.
So it says the same. Nico, can you guide me? Where should I? Yeah.
It's not on slideshow yet.
Yes. Thank you. Thank you, Nick.
Perfect.
Hi. Just. Hi. Hello, everyone. My name is GB Matthew. I'm a senior researcher working at the University of Jyväskylä, Finland. And first of all, I would like to thank the coordinators for giving me the opportunity to present my research, and also thank you all for joining this session. And today I'm going to talk about care poverty in different sources of care among older people, which is based on the book chapter which already Teppo introduced. It is the title Care Poverty and Unmet Need, edited by Teppo, Nick, Ricardo, and Christine. And my chapter is co-authored with Lina and Teppo. So the background in today's world, meeting care needs of older people has become a global concern due to aging, population aging, and also increasing demand for care, as well as there is also a shortage of human resources and also financial resources. Older people have very different and unequal resources and informal network when it comes to care support. Some get help from public service, some who can afford look for service in the market. Others rely on family or friends, and many of them combines all these services. But there is also a certain group, those who without no resources or limited resources live without care support. So here in this context, I ask this couple of three research questions. What kind of care support do older people use? Whether it is a formal only or informal only or both? And how common is care poverty in each group? And what individual and societal factors lead to care poverty in each group? We want to understand how unmet needs differ depending on the type of care the older people receive. I'm not going into it. Already Teppo has introduced this concept as care poverty. So care poverty means people who need help don't get enough support, either from formal or informal care. It's a deprivation of resources. It's also a structural issues linked to undervalued services, policies, gaps, and social inequalities. In this study, we use to understand this research question, we use a common, well-known framework, established framework for understanding care poverty and source of how people use different source of care and what are the determining factors. And as you can see in the left side and the right side of this slide, you can see what are the variables we use in the analysis. So social, most important we found is like health and functional status. This is most important factors, as these factors determine care needs. When there is health issues, the need for care increases, and that determines the type, amount, and source of care, source of support they required. And the social demographic background also influence, and access to care also influence the health and functional status. Whereas social demographic background and access to care determines where care resources come from and how they use. For example, maybe people with low economic strata may have less resources. Same as where they live. With whom they live and their social network all determines how they use the service and how they receive the services. So when the services are not adequately met or there is no care received, then we can consider it as a care poverty. maybe I will give a short, brief description about the Finland, as this research was conducted in Finland. So Finland is often considered as a welfare state, where public is more public sector plays a predominant role in organizing care for older people, or care for its residents, actually. However, in the last 2 decades, there is the social care service for older people has been in a state of flux. For example, there is services are increasingly targeted with people with demanding care needs, and there is also tightening of eligibility criteria for receiving services. And the marketization of care is also plays a role, where people are encouraged to purchase private services, especially for support services or practical care needs, services that relate to practical care needs. And refamiliation, more importance is given for family care, even though family members are not legally obliged to provide care for or pay for the services for older people, but many do in order to take care of older people. So in this context, we conducted this. This is the country level context, and our data for this study comes from a national survey conducted in Finland in 2020, and we collected data from 75 plus or 75 and above older people. For this study, we used only who need care. So the total response rate for the whole survey was 55%, and for to understand care poverty, we use these questions of how they manage their personal and practical care. And for personal care, there are 5 items from bathroom dressing, and for practical care, it's more like a practical related items: cooking, getting home, and getting out of help. And they have 3 options: I manage well, I do not cope, I get enough help, and I do not cope, I need more help. And the last option was we consider this as an unmet need and care poverty. The background is like most of the respondents were women aged 75 to 84 with sufficient income and education. Health and functional status were generally good. Many live alone, but they have a very strong informal network. And among the respondents, around only 2% use formal care only, and 54% use informal care, and 44% use both formal and informal care service. And when we are looking at how the unmet practical care needs, how the unmet practical care needs are, there we found like 18% of them practical care needs are unmet, and 2% of the personal care needs are unmet. And this figure shows the met and unmet personal and practical care in different sources. As you can see, most older people care needs are met, and unmet care needs more common seen in those people using both formal and informal care. That means that both people who are using all kind of resources, like informal and formal care resources, they have the highest unmet care need, which is like around 29% in practical care needs. And there is also some 11.4% of unmet care need in informal care only group. We further looked into what demography or health and access to care factors, what determines or what influence associated with unmet care needs in both practical and personal care needs. Due to the insufficient number of respondents, for example, in this one, formal care need equal to N equal to 5 and informal care only group equal to N equal to 88. And the unmet need is very small, that is 4.5%. We have to exclude these two groups. And in practical care needs, we have to exclude the first group, formal care, only because N equal to 38 and the unmet need care is really 15.8%, which is 5 to 6 respondents are in that group. I think it's 5 respondents in that group. So we have to exclude these 3 groups for when we are doing the regression analysis. When it comes to predict unmet practical care needs, older people with adequate income, poor health, and greater number of care needs are more likely to experience practical care poverty, regardless of whether they combining formal or informal care or only informal care service. Among those receiving only formal care, living alone and having less frequent network is also an influencing factor. Overall, the findings suggest that income and poor health are a very influencing factor for unmet care needs, regardless of the support they received. It could be either from informal care only or combination of both, combination of formal and informal care in practical care needs and also in personal care needs. So in conclusion, in general, older people in Finland are more likely to experience practical care poverty than personal care poverty. Unfortunately, there is a lack of sufficient data to analyze personal care needs because we don't have the respondents we received through survey are most healthier, and they are not from this specific group who need or who require more personal care needs. So we lack that information. And several inequalities can be visible from this study. That is, less well-off and having poor health are more likely to have personal and practical care poverty. Living alone and lack of social network have an influence on practical care poverty. So unmet care needs are relevant among those using both formal and informal care, despite using both kind of service. So this phenomena raises a crucial question, like why do older people's care needs remains unmet despite or even though they are having the access to all kind of service, so all kind of resources. So this is quite an interesting question, and I know that the care needs are quite complex. So being left without adequate care is a greater concern, as Teppo already mentioned. Like it's like more deprivation of human needs. It also impacts the well-being and health of older people. So I like to even as I mentioned like before, like we have very limited detail on data on personal care needs. So the results of this study is primarily, or maybe I could say like more focused on the issue of unmet practical care needs rather than the issue of personal care needs. But nevertheless, unmet practical care, the studies have shown that unmet practical care needs also influence the quality of health and also influence the personal care needs. It's also like older people, people should have sufficient care to meet their care needs. And this is our chapter which we discussed on this paper, on this topic. And thank you.
Thank you, JB. We, unless anyone's got a burning question that can't stay to the can't wait until the end, I'll introduce Tasha Potocznik now, who's going to talk about another aspect of, well, a related aspect of care poverty. So over to you, Tasha.
Thank you, Nick. Hello, everyone. I'll just share my screen so you can see my presentation. Okay. I hope everyone sees it. It should be
perfect.
Okay. So hello from my side as well, and thank you, Nick, for the invitation. I'm Tasha Potocznik, and I'm a research assistant at the Faculty of Social Sciences at the University of Ljubljana. And today I'll present the socio-economic differences and care poverty in Slovenia. I'll speak about the chapter that was written in collaboration with colleagues of mine, and that's titled Pathways to and True Caring, Family Care, Socioeconomic Differences and Care Poverty. But before I start and present the findings, I will just briefly outline the long-term care system in Slovenia, how it's organized, so that you'll have a bit of a background of where the study was conducted. So Slovenia is a very interesting country when studying long-term care provision, because we have this dichotomy between care for children being defamiliarized and care for older adults very familiarized. We also have a legal obligation of adult children to cover the costs of formal care services if their parents' income is insufficient. Family care is kind of a norm, and it's the most, it's a predominant form of long-term care. However, it's, and as in many other countries, women are the ones who are providing, especially the majority of this intensive care. But it's interesting that, for example, in Slovenia, we also have high female full-time employment rate compared to other European Union countries, and very low part-time employment rate, meaning that often informal carers, particularly women, have to have many care obligations and have to balance work and care. And there is, up until very recently, the long-term care system was very fragmented. There was very few support services for informal carers. And in 2023, we adopted our first Long-Term Care Act, which I will tell you more about in the discussion about the potential of this act to address care poverty. But for now, also the one additional important factor is poor financial situation of older people in Slovenia, especially older women. As you can see the numbers on the slide, the risk of poverty in old age is very high, especially for women, and it increases, the gap increases with age, with 25.2% of women over 75 years of age living under the poverty threshold. This poor financial situation of older adults is also one of the reasons when negotiating the care arrangements, because for many older people with care needs and for their families, for example, institutional care for those with low incomes is not an option. Frequently, they don't even think about it because, for example, the average pension is about 700 euros. However, and in our studies, we had like older adults that had in their employment history very many like caring obligations, and they weren't present on the labor market, and that and for example also the farmers, these specific risk groups were identified that they had like their pension was even lower, like 200 or 400 euros, but the institutional care often costs around 1,000 euros. And with the legal obligation of adult children to cover the costs, often this type of arrangement is out of the picture. But we also have formal care services, and which enable people to live at home, but with, of course, with support from informal carers as well. So formal care services in Slovenia are provided to approximately 1.7% of people aged 65 plus, but there are high regional inequalities in the provision of home care services and in affordability, about which I will speak a bit later. And for older people to be eligible to home care services, they need to need support with at least 2 out of 3 needs, either help with ADL, EADL, or with socio-emotional needs. And the service is covered from a combination of subsidy from the municipality, which has to be at least 50% of the price, and out-of-pocket payments from users or their family members, and because municipalities differ between there's a difference between municipalities in how high this out-of-pocket payment is. There are also high inequalities in whether the older people and their carers can afford it. So we did a qualitative research based on 54 semi-structured interviews that were actually gathered within a project exploring and understanding the determinants of care provision for older people in the community. We decided to use the relative approach to care poverty, and we looked at whether the care received is sufficient or not. And we used the dyadic approach, where we studied caregivers, but we assessed the socioeconomic status of both caregivers and care receivers to see from what kind of what is the socioeconomic status of the diet from which the caregiver is coming from. So the research question we posed is how the socioeconomic status of the caregiving diet shapes family carers' pathways to care and through care, and what are the consequences for family carers in terms of choices, well-being, and unmet needs. So we focused a bit more on carers, and in today's presentations, due to limited time, I'll focus on this navigation of care obligations on the second part of the research question. So if we move to the findings, we found that one of the main reasons for unmet needs among caregiving diets is insufficiency and inadequacy of formal home care services, especially affordability of home care services, because there were differences between diets in whether they can afford formal care services, and because formal care services in some municipalities weren't available in the amount needed, also whether they can afford to fill the gap of these services. And we found that the gap was often filled. The low socioeconomic status diets often struggled paying for the home care services, and they couldn't outsource care on the market, a strategy that was used more frequently by those who had higher socioeconomic status, who have higher income, and who could afford the outsourcing of care. For example, here you can find the citation from a middle class caregiver who says that because the financial situation of them changed, and they have a financial issue to provide care, sufficient care, and that they would need more care, but they can't financially, it's not financially feasible. For example, we had, I didn't put it on a slide, but we had caregivers with more financial resources that had 2 or more private caregivers paid, so they could place they could care for they could provide care for their care receiver, and to cover the gap that was left by the formal home care services. And here's the map where you can see the price of home care services across municipalities. And in the research, we found that there's the price for home care service in Slovenia per hour ranges between 2 and 12 euros per hour. So that's a quite big range, and quite a big inequality in out-of-pocket payments for users and their family members. Also, one interesting finding is the availability of home care services changes and affects the unmet needs of caregiving diets, because in some municipalities, home care services are available only on work days. In others, in one that's marked yellow on work days and on Saturday, and in the green ones available every day of the week. And also one important reason for unmet needs and was in the fact that there were workforce shortages, and the provider of formal home care services couldn't grant older adults the enough home care service they need. Also, there were waiting lines, so people couldn't receive home care when needed, and that created differences between those, again here, those who could afford to pay to outsource care were better off than those who couldn't. We found that okay, so here is a citation that says that even though the policy in the Social Assistance Act, it says that older people are entitled to a certain number of hours per week. For 2 visits per day, they couldn't provide it because of work shortages. And again, the caregivers needed to fill the care gap. Interestingly, we also find that, and it was across all diets, that formal carers were prohibited from performing certain care tasks like nail clipping and bandaging the legs, and
Sure, 1 more minute, if that's all right.
Yeah. And additionally, lack of information and knowledge about specific care tasks were emphasized from caregivers to be an important unmet need, because they didn't have knowledge how to provide care, how to seek professional care, how to access care. And among those who balanced work and care, a lot of their agreements were based on employers' goodwill and informal arrangements, where they adopted strategies to balance work and care that were very unsustainable and often led to unmet needs. So what we concluded is that socioeconomic status is a risk or protective factor that especially in Slovenia, especially people with low diets with low socioeconomic status have issues with accessing care. And what it also resulted from our research is this, that care poverty of older adults has consequences for caregivers. And a question that we frequently ask during the writing of our chapter is whether we can have a more dyadic perspective to unmet needs and to care poverty, because we saw that care poverty of older adults often resulted in unmet needs of family carers. And if you have it's a high risk that caregiver with unmet needs will, whether or not to provide insufficient care, and it's kind of vicious circle, I believe. So,
Tasha, can I stop you there? That's all right. Sorry, I want to leave time for Ricardo. Thank you. Super interesting presentation. So I'm going to quickly hand over to Ricardo to summarize, lead us on the discussion and everything else. So Ricardo, over to you.
Thank you. Thank you very much, Nick. Welcome, everybody. Greetings from my side. I will go without further delay into sharing my screen. Hope you can see it now. So what I'm going to do is building up on basically on the book that the other presenters already referred to, but also in a recently published journal article where we sort of take a little bit further, not so much the concept, but an overview of the landscape in terms of the current research on care poverty. I'm going to try to give you an overview of where we are at, and more importantly, I think for the context of moving forward with the present group, see what could be possible gaps or areas where further developments are perhaps needed in the context of care poverty. So we know that care poverty is still a new and still developing concept. There is already sort of a toolkit for its measurement and assessment. We had here today 2 presentations that provide us two very good examples of how to assess and analyze care poverty, but this is still very much evolving as well. And we have sort of a increasing body of evidence, of information, of literature, studies, if you like, on the matter or using this concept. But this is, given the sort of the youth of the concept, this is still somewhat uneven, and there's still gaps there. So I'll very briefly touch upon each of these aspects. So in terms of the concept itself, and I have here one concept, sort of one definition that I took from the book. It is important, I think, to recognize that the concept has so far relied or very much been driven by sort of the academic voices, especially from the global north. So we are in need of sort of a greater co-production by, first of all, those who are directly affected by care poverty, not only older people, but as Tasia mentioned in her previous presentation, also of informal carers, professionals who might also be affected by care poverty. It would be great to have their views and incorporate them and see how their views might challenge our understanding in our definition of care poverty, but also perspectives from countries where not only care poverty, but material deprivation and poverty are a reality for a large share of the population. And again, might have a different experience, a different understanding of what the concept should be about. We've focused so far very much, and we highlight that both in the book and in this journal article as areas to develop further. We focus very much, or we've focused very much so far on the concept of care poverty and unmet needs, very much in relation to the activities of daily living, which if we take Amartya Sen's approach, this poverty framework approach, this probably comes close to what he defines as functionalities, and maybe we are not paying sufficient attention, or haven't paid so far sufficient attention to the so-called capabilities. So all these resources that lead towards, or are more relevant towards, the self-determination. And I think that's an area still to be explored, an area where qualitative research could play a very important role in uncovering these other needs. So this is in terms of the concept itself. In terms of the existing evidence, this is a table I took from one of the chapters in the book. We tried to sort of, at the time, map a little bit some of the studies we have using, or not, sort of some of them using in a more evident way the care poverty than others, but still using also different poverty thresholds and ways of defining and measuring care poverty: one-dimensional, multidimensional, subjective, objective, etc. So different ways of assessing care poverty. And what we see here is that there's definitely been a concentration in terms of one-dimensional absolute measures of poverty on the one hand, of care poverty on the one hand, with subjective measures following close by. But there are areas that are still sort of empty in this map of ours. Among them, studies using objective poverty thresholds, care poverty thresholds that rely on a more relative measure of poverty. And I think this could be relevant, especially, and that's one thing that I think still needs to be, there's still a gap in our toolkit in terms of how to assess and measure care poverty, which is to develop ways in which this could be measured pretty much in relation to how we do it for income poverty, to do it in a relative way. So in relation perhaps to the overall distribution of care within different societies. And we feel that this could be particularly relevant when using, or when applying this concept in a comparative setting across countries. We also have so far not really addressed the issue of intensity of care poverty. So, and this is something, it is a concept that would be relevant also very much from a policy-making context. So how far off are we from the threshold of care poverty? How far off are individuals and societies from being able to fully address needs? And of course, we've had so far especially in the quantitative data that we've used in these studies, very limited information about causes for the mismatch between needs and care. So that's something also that needs to be addressed in the future. So as I said, this is still a concept that is new, it's evolving, and these are, if you like, some of the gaps or underdeveloped areas in terms of the existing evidence. And that is something also to tease the imagination of the members of the network and the group here present in terms of future research. Some of them relate to things I already mentioned in terms of the need to take the concept further, for example, in terms of the geographical scope and how this remains limited, even within Europe. So we have still a dearth of studies from Southern and Eastern Europe, for example, not to mention very much of a glaring gap regarding the Global South. I was mentioning the previous slide in terms of the limited information we have about the causes of care poverty. This very much pertains to the fact that we have so far, again, especially in quantitative studies, used secondary data that has not clearly been purposely built, with a few exceptions. A couple of the studies from our colleagues in Finland has not been purposely built to collect information on care poverty. We've sort of repurposed it, and authors have repurposed it, and very nicely so. But there's a gap there in terms of the causes. Something I think that we still need to do something about, sort of unpacking potential intersectionality across different groups and how that concept might help us explain different forms of care poverty. And to finalize, I would say that we also have been missing so far studies that take this comparative care policy approach to care poverty, and that would hopefully enable us to also get a better understanding about what kind of policies, what kind of approaches, measures, or contextual factors might explain different degrees of care poverty across different societies or systems. So I would leave it there in order to still leave a little bit of time, hopefully, for inputs from your side, for comments, reactions to what I've just said. And I'm very much looking forward to further inputs from the members of the group.
So we are at the end of our time, unfortunately. So, but if anybody wants to kind of stay for a couple of minutes and ask anything or contribute anything, otherwise, I think me, Teppo and Ricardo are very happy to kind of continue this conversation and hopefully at the next webinar as well. So I'll just quickly say thank you to the presenters for people that need to leave, but yeah, do get back to us on anything.